Assalamu alaikum. Hello, everybody. First of all, I would like to thank Professor Dr. Ahmed Samir and the organizing committee for this kind invitation. I'm highly delighted and honored to participate in this event, and I wish next year I would be in person to meet everyone and to exchange the knowledge with everybody. The topic today is about how to approach a cardiac MRI scan, which is a big topic. So I will try to draw a kind of an outline algorithm how to approach a report or a scan of cardiac MRI in regards of cardiomyopathies. Congenital is a separate topic and it would be very difficult to include in today's presentation. So I will try to outline how an algorithm could make it easy and simplify how to reach a conclusion and a recommendation that could impact the clinical management of the patients. I have nothing to disclose. So in order to approach a cardiac MRI, it's a dynamic process that it starts from the very beginning with the patients themselves. So the first step would be investing time in the MRI scanner, investing time with the patients in order to tailor some sequences that would take you, of course, through a systemic approach to reach and achieve a structured report that could have an impact and clinical impact on the patients. And so starting with the first one, the more you invest in the room, taking history, we all are radiologists struggling with the clinical history that is missing. It is not telling us the entire story. Clinicians are sending us a kind of a half of 50% of the story. So the 50%, the other 50% lies with the patients, talking to the patient, invest time in the scanner, train the patient also, educate them what is expected, especially if it's a stress study, what is the experience that they will have. That would help you, of course, to tailor the protocol, because from the history is sometimes, even if it's not told there is a ischemic or non-ischemic, you could tell from the history that would take you either ischemic viability stress direction, or is it non-ischemic in the direction of maps or 4D flows. So it's a different approach for this cardiac. So the more you invest, the easier the report and the better outcome, because you will reach a structured report. Where some colleagues would use organs, for example, they would go through the extracardiacs first, some would then move to the ventricles, to the atria, to the valves, to the kind of the great vessels, pericardium, and then you could reach a conclusion because you will build up a case. Some colleagues will go through it by the sequences, so going through the localizer and then the cines, which are the backbones of any cardiac MRI, and later on flows, if they have done flows, and what does it mean, the post-processing of the flows, is it valvular diseases, or then maps maybe, or edema sequences, early gadolinium, late gadolinium, in order to reach a diagnosis. Both routes are fine and both routes should achieve the same goal at the end, either by organs or by using the sequences that you have performed. And always believe your eyes. Post-processing should help what you are viewing on the images. It's a common knowledge. Cardiologists, surgeons knows how to check the scans by themselves. So it's important what you see matches what you get from the software. If there is a discrepancy, then always check your contouring, check the numbers that are coming from the software for any mistakes, and always believe. So if the image is telling you it's an impaired ventricle, it is an impaired ventricle. So always train your eye on eyeballing. Is this regurgitation mild, moderate, or severe? Is this impaired severely, or is it mild? Before getting the results from the softwares. Sometimes I use the structured report using the sequences. For example, that was referred for a stress study, and I saw this signal in the right apex and the lymph node. I was suspicious of cancer because the patient was complaining of shortness of breath. It didn't turn out to be cancer, but we didn't do the stress. It turned out to be sarcoid. So we didn't do the stress. We did just edema sequences and a viability sequence or late gadolinium enhancement, which showed non-ischemic enhancement. Later on, the patient received a CT and PET, and it was not a stress study. It was a cardiomyopathy study. Similarly, here that was a report saying ARVC because they requested the clinical data, dilated right side, suspicious of ARVC. Yes, everyone in the room is saying there is a partial anomalous, and this case had an ASD as well. So that from the localizer you could identify anomalies, and this would let you plan the entire scan. If I knew that this is a congenital, then I will not give contrast. Similar for the example in the cine images, when we detected this, I promise that I'm not going to go through congenitals, but for example, that was an ARVC request, again, there was a big ASD, so we didn't give contrast. We didn't do it as a cardiomyopathy protocol. So invest with the patients, invest in going through the sequences in a structured or a systemic approach. Then that would help you to tailor what sequences do you need to serve an outcome for the patient. So in general, cardiomyopathies will be divided into two main categories: one ischemic, two non-ischemic. Ischemic category, or the first category, would be the ischemic. Of course, the clinical history: anginal pain, chest pains on exertion, if it's an acute admission, ECG changes or troponin rise, and please always check for the cath labs. It will tell you most of the story. And in the cine images, we know on the localizer maybe you would be able to see pulmonary edemas and effusions if it's acute, but on the cine it's important that we will see dilatation and also akinesia, hypokinesia, that are following a territory, a certain coronary territory, similar to what we see in the brain. If there is ischemia from a tumor, we could tell from the edema, is it territorial or not territorial. Similarly, in the heart, we could tell from the wall motion abnormalities if it's territorial or not territorial. So the cine could guide me. Now I'm guided that from the cine. I knew already that this is going to be a viability, so maybe I would add edema sequence if it's acute, maybe not if it's not acute. So I could bypass and skip a lot of sequences and save a lot of time. Similarly, for the edema here, if it's territorial, then I know that it is following an ischemic route. And here it was an LCX, that was an acute case, or acute ACS. Here in this case it's the LAD, and we know from the gadolinium, this is from the cine, from the edema, it's telling me already what is expected to see in the gadolinium enhancement image. So now in my head, if it's an early, if it's a viability study, then possibly we will need to do early GAD plus the late GAD. So early GAD usually is 1 or 2 minutes after contrast injection, opposed to the late GAD, which is 5 minutes plus after the gadolinium enhancement, in order to identify areas of thrombi or MVO, similar in this case. And the late GAD would tell you, of course, the extent of the murality or the transmurality. Is it subendocardial, like in this case, or transmural, similar to the previous case? And of course, that would be along a certain coronary territory, involving a certain coronary artery. In that case was the LCX. In this case is going to be the LAD with a large area of MVOs because of lead occlusion or LAD occlusion. Always, if you reach the diagnosis, go beyond, because it requires prognostic factors for those patients, risk stratification. Would that patient expected to be admitted in the hospital in the next 5 years? That is for the MACE risk stratification. So go beyond in the functions and the volumes, the MVOs, and the amount of the MVOs, and also if there are other things, for example, thrombi in the left ventricle, and also the forgotten ventricle in ischemia, so a thrombus in the right ventricle, or if there is a pseudo aneurysm or a true aneurysm. Of course, those factors would tell you what is the prognosis of the patients. For example, the in acute events, you could add the T2 star in order to identify intramyocardial hemorrhage. So knowing that is in the ischemic route, you could plan and tailor according to, is it acute, is it chronic, so you can reach and achieve a lot from a cardiac MRI. If it's a non-ischemic, then the algorithm would be you ask yourself from the localizer and the cine, if it's hypertrophied, then is it symmetrical or asymmetrical? If it's not hypertrophied, it's in the category of a dilated cardiomyopathy, then is a long list. Then I need to exclude valvular shunts, inflammations, medications. Is it an athlete heart adaptation? So there is a long list of factors that I need to, or diagnoses that I need to exclude before reaching that this is an idiopathic DCM. Of course, sometimes if check on the localizer is the pericardium that is affected and that is affecting the heart from outside. European Society of Cardiology dismissed the non-compaction, and they are describing it now as not a separate entity of cardiomyopathy, it's a hypertrabeculation. And the American Society of Cardiology is on the opposite side. They are describing it still as a cardiomyopathy. So let's say the algorithm, I'm viewing now a cardiac MRI scan, is it ischemic or non-ischemic? And we know ischemic from akinesia following territory, late gadolinium subendocardial to transmural. No, it's non-ischemic. Okay, is it hypertrophied or dilated? So let's start with the hypertrophied ventricle in a non-ischemic cardiomyopathy. And what does it mean, symmetrical, asymmetrical? Of course, at the basal cuts of the cine anteroseptal, measure the ratio between the anteroseptum and the posterior wall. Exceeding 1.5, that is going into the direction of the sarcomere, HCM, for example. It's telling you that is asymmetrical hypertrophy, which will not happen in the symmetrical form. There is a long list, and why this algorithm is helping in the differential diagnosis, because those that causing asymmetrical are different than from, or almost different from, the list that is causing symmetrical hypertrophy. And accordingly, for example, let's start with the asymmetrical HCM. Of course, if I know it's an HCM, then I might add LVOT in order to diagnose Hawkins and obstructive types of HCMs, and I will understand, okay, what is expected, the typical form, which is the anteroseptal, or is it the apical, the less frequent, or the rare forms of symmetrical that might confuse me with the other types of cardiomyopathies. And also I will understand where is it expected to find the late gadolinium enhancement, which usually along the hypertrophied segments. Always also be aware of the atypical forms, where it sometimes might affect the anterolateral wall instead of the anteroseptal, and be aware also of the late stages of burned out hypertrophic. Because of the severe hypertrophy, it might lead to impaired systolic function instead of hyper dynamics. Non-ischemic also in the HCM, we know that the late gadolinium will be in the hypertrophied segments, non-ischemic form, so it's not subendocardial, it's in the mid wall in those areas. And please try to measure the burden, because that is going beyond now the diagnosis. That is risk stratifying patients. We saw many professional players that died on the pitch because of HCM. If the burden is above 15%, they are indicated and justified to have ICD implanted. And that takes me to the new era of the professional that are playing athletes. So now sports, according to the sport, of course, if it's endurance, it might lead to a dilated ventricle. But if it's one of those trends like weightlifting, it might lead to symmetrical. Now we are going into the differential diagnosis of symmetrical hypertrophy of the left symmetrical hypertrophy. Sometimes even the function might be on the lower side, so around 50% to 55% is accepted. However, never goes to the moderate dysfunction. Practicing sports that is strength sports, or that there is a history of hypertension, which is another cause of symmetrical hypertrophy, sometimes accompanied, associated with low function, sometimes with preserved function. Sometimes it shows early subtle changes, elevated T1 maps without even lead gadolinium, but on the localizer you find atherosclerotic changes, so like dilatation of the aorta, that would help you and guide you in direction of hypertension. Always check for the valves. Sometimes the cause of the symmetrical hypertrophy lies within the aortic valve, degeneration and calcification causing aortic valve stenosis with jets of aortic valve stenosis. Um, Another case of athlete with low function, we said never moderate, never severe. So if it goes in the moderate and you know it's an athlete causing symmetrical hypertrophy, but on the late CAD in an athlete adaptation, physiologic adaptation, never, you will never find a late gadolinium enhancement. If you find, then always think about there is another factor. If there is any medication that led to a kind of vasculitis, so we need to be aware also of in those symmetrical in the athlete. If there is late gadolinium enhancement, sometimes there is the enhancing substances that might lead to vasculitis, that might lead to late gadolinium enhancement. Amyloid sometimes symmetrical, sometimes asymmetrical, but with a low function, signs of heart failure. And of course, on the localizer, you might find pulmonary edema because of the heart failure and the extensive late gadolinium enhancement that usually non-ischemic sometimes extends also to the atria. Sometimes it's both left and right ventricle involvement that you will not find in ischemic form or HCMs. In Fabry, usually here the map will play a crucial role, where the map will be in the low side because it's intracellular, and that is the areas where the maps will play a major role that could tell you is it intracellular deposition or extracellular deposition, unless it's at the fibrotic stage of the Fabry where it increases the extracellular volume. Dilated, so now we're moving from the hypertrophied to the dilated. And what does it mean dilated? 6 centimeter and above on echo, or 100 milliliter per meter square on MRI, that identifies a dilated left ventricle. There is a large list of causes of dilatation if it's associated, for example, with akinesis and dyskinesis areas on the right ventricle. It might be one of those ARVCs, or if or it might be disabling of ARV that would be on the left side, dilatation, thinned out, low function, plus this enhancement that is sub-epi, sometimes mid-wall, and you will see it's almost circumferential, the entire left ventricle. So ARVC, ALVCs, or simple factor causes similar to this case, where we could see there is a mitral annulus disjunction associated with severe mitral regurgitation and some fibrosis at the basal, mid-wall, non-ischemic. So this triad might be arrhythmogenic. So again, we finished the non-ischemic hypertrophied ventricle. We are moving toward the dilated non-ischemic. We checked for some cases, check for the valves. Here we are moving to the inflammatory causes of myocarditis. Usually on the edema sequences, it will be in the subepicardial. Sometimes it's patchy. And of course, the late gadolinium enhancement will be on the non-ischemic side. For example, here in this case, here patchy, and in this case is in the subepicardial, typical for myocarditis. And that takes me to a new era of myocarditis on top of oncologic therapies that sometimes leads to myocarditis. So we need to be aware of this entity. For example, in cases where there is advanced metastases, and using those chemotherapies or the immune inhibitors, sometimes they lead to myocarditis in the form of one criteria from the Lac-Louise. It doesn't have to be the full-blown criteria, so you don't have to see late gadolinium. Sometimes only the edema would be diagnostic because it's fatal, the myocarditis in this patient group. Sometimes the disease is coming from, yes, outside, so check the pericardium in all cases. For example, in this case, that was a pericarditis. Adding flows, it depends. Please tailor it according to the case. So if you see from the very beginning there is suspicion around the mitral, so in this case the 2D showed, but the echo was showing another gradient that was underestimated on the 2D, so we added the 4D. It takes around 10 minutes sometimes, so it's valuable. Don't do it or add it in all patients. If you think that would be useful and helpful, then add it. If not, tailor according to the clinical history. Similarly, the maps, we use it to identify intracellular from extracellular T1s that could tell you what type of non-ischemic cardiomyopathy that you are facing, but you don't have to do it in every single case. That algorithm, I found it from the American Journal of Radiology. It's more or less similar to the algorithm that I'm using, but maybe in a different way. Whenever I have a case of cardiomyopathy, I ask myself, ischemic or non-ischemic? If it's non-ischemic, is it one of the hypertrophied, so symmetrical, asymmetrical? Is it dilated? And I have to go through the entire differential diagnosis: inflammatory, oncologic, valvular, ALVC and ARVC. So you have to ask yourself, hypertensive cardiomyopathies, or is it coming from outside? So I need to check the pericardium, or is it one of those unclassified? I hope that was a useful presentation, and thank you very much.